Welcome to the Navigating Dental Insurance Podcast, where we don't take from insurance companies. Here are your hosts, Mr. Jordan Comstock and Mr. Ben Tuine.
Welcome to another exciting episode of the Say No to PPO's podcast series. My name is Ben Tuine. I'm a co-host on the Navigating Dental Insurance Podcast. We appreciate you being on the show today and chiming in. Today I'm running solo. Jordan Comstock is not available, and that's been the trend for the both of us over the last several weeks. I've been out of the country and have had some at-home issues here in Utah that have kind of kept me out of the office for the last couple of weeks. And today Jordan is out working on a business issue, so he extends his apologies for not making it today. But I'm here to take care of you. And fortunately, we do have an awesome guest with us today. We have Glennine Varga on the show. Glennine, how are you?
Hi, good. How are you guys?
Excellent, thank you. Thanks for taking time to chat. Your topic is something that we've been focusing on quite a bit. So the doctors know, because in the title it says medical coding, and we're going to get into that here in just a second. And the reason why I think this is an important topic is I get questions all the time. Is dental insurance consolidating into medical insurance, and is dental insurance going to go away? And so we'll address that. We'll get your opinion, and I'll chime in on some industry facts as it pertains to that particular question.
Okay.
But you and I got started through conversations with Arrowhead Dental. So we'll go into that, but our listeners would love to know, Glennine, how did you get involved in dentistry? What's your background? How did you get started in dentistry, and how did that evolve into what you're doing today?
Sure, absolutely. Well, we can go back to when I was little. Just kidding. I won't take you that far. No, I've always wanted to be in dentistry ever since I had ortho, in my teenage years. But I started working in a dental practice in Colorado, and I wanted to go to school to be a hygienist. And I thought if I get all my prerequisites done and get a job in a dental practice, I'll have better chances of getting into hygiene school. But once I started working in a dental practice, they actually put me on insurance. They had a lot of outstanding claims that needed to be paid. And they said, hey, you're a college student. Why don't you go back and see if there's anything we can, get narratives in or help recoup any of this insurance money that's out. So that's how I started at 19, actually, in the dental practice. And, I just started asking, what's mesial? What's distal? What are these things I'm putting in narratives? And my office showed me, and they gave me the opportunity to become an expanded duties dental assistant. So from there, I took off because, no offense to our awesome hygienists out there, I just felt that it was very repetitive for me. And I actually got a thrill by assisting when it was an extraction or a root canal or ortho. Our procedures constantly changed, and I actually loved it. So I excelled as an expanded duties dental assistant. And, just the office I was in, we were, looking back on it, we were very advanced at the time. We were doing a lot of comprehensive dentistry and full mouth dentistry. Looking back, I didn't realize that we were in a practice that had been trained by Dr. Dick Barnes, and we were trained on how to look for comprehensive dentistry. And so that's all I really knew. So fast forward from there, I became a trainer for medical billing software, and I also became a trainer for electrodiagnostic equipment. And from there, I just started taking tons of CE. Every weekend, I'd go to a CE course on medical billing or sleep and breathing or TMD or something. So that's been 20 years in the making. So here we are. I'm working exclusively for Arrowhead Dental Lab. I am their business development coach and sleep breathing coach. So I'm, helping offices navigate medical billing and understand what they have to do to get that type of treatment going in a dental practice.
That's pretty cool. So when you started in dentistry, did you do any medical billing at all, or did that come when you started working for that medical company that you mentioned?
I would say probably about 5 years into my job, we started to see a lot of patients that had a lot of TMD problems, a lot of temporal mandibular disorder, headaches, jaw pain. And so we went to a medical billing course, and I learned how to do medical billing, and we got software to help us. And so that kind of started my journey. And so we would do what we could. It's not always easy to bill medical, but whenever we could, prove medical necessity and write narratives to, be able to fight that fight, we would see some reimbursement and some benefit for our patients. So it worked out really nice.
Gotcha. Some in the industry say that dental insurance billing has become increasingly difficult over the last 10 to 15 years. What do you experience with medical billing? Does it get harder or easier as you get to know it?
Well, that's a really good question. I would say over the journey that I've had in experience with medical billing, it's actually become a lot easier. And I really think that has a lot to do with obstructive sleep apnea and insurance companies, including Medicare, writing policies to allow benefit for oral appliances when patients are diagnosed with OSA. And so because of that, I feel that it's opened the door to allow other procedures done in a dental office that could be billed medically. And so in my experience, I've actually seen it get better. However, I think you kind of have to look from everyone's perspective because, obviously insurance companies do everything they can to make it sometimes difficult to get that benefit back for our patients. So I guess you just have to, it's the way you look at it.
Yeah, no, I think that's the feedback that I'm getting is that initially tackling medical billing is really difficult to the extent where many offices would go to these awesome CE courses and would invest thousands of dollars learning how to get into medical billing. Mm-hmm. But 3 months down the road of their journey, they give up because they just can't get the insurance carriers to do anything by way of paying for claims, or the practice is just frustrated because they don't understand the process.
Sure.
But most everybody that I talk to that understands medical billing says it's actually getting easier and easier and easier, and more procedures are being covered under medical insurance, which leads into the question that I asked at the beginning. Is dental insurance going to go away? Is it going to be consolidated under medical insurance? What's your thought on that with what you're seeing in terms of coverage? Are we seeing an evolution of plan design shifting to medical?
I think it's just in regards to dental offices and what we're looking at. As we evolve as a dental industry, you see us looking more at things that are connecting, the oral systemic connection and looking at other things that we can do in a dental practice and how it plays a role with our medical insurance. And of course, obstructive sleep apnea and patients struggling to breathe at night really, plays an awesome role in writing policies and making things medically necessary for benefit or for coverage. So that's a huge plus in our favor. But I think at the end of the day, it's all going to boil down to, is the procedure that we're providing for a patient medically needed? Is it medically necessary? And if it is, and we can prove that with a report or with codes, then I always think it's going to be possible for these insurance companies, these medical insurance companies, to offer a benefit. And, to say dental is going to go away, it's so hard to tell. I mean, in 1960, we had the same benefit as we do today. So, we haven't seen much changes going on in that way. So I hate to say it's going to go away. I don't think it'll ever go away. But if you equate $1,000 in 1960 compared to what that $1,000 would look like today, I want to say it's less than $20,
right.
the conversion rate. So I like to lean on medical when things are appropriate and there's benefits there for the patient. Heck yeah, I want to do everything I can to help help our patients maximize that benefit.
That's awesome. And I think that provides both you and the patient with more options.
Exactly.
I'm starting to see a lot of things get covered under the medical side. Perio's being covered, extractions, implants, the whole, yeah. And it's amazing. There's some practices that are getting $30,000 to $50,000 in a single check from a United Healthcare Medical or a Humana or Aetna Medical. And it's just amazing to me that, this is treatment that patients are receiving and not having to bear the majority burden of costs out of pocket simply because there was medical coverage available.
Exactly.
Which leads me to believe that I think it's really key and important for practices to learn to understand medical coding and medical billing. I don't think dental insurance is going to go away either. In fact, dental insurance has already started to evolve. I received a notice earlier this week from an insurance broker that we work with. He sells medical, health, life insurance, casualty, and property. And he sent me a solicitation from a large insurance carrier. I'm not going to name them here on this call, but the offering was a $5,000 annual max. And I read through the policy. Of course, I'm really skeptical when you look at anything as it pertains to insurance. I don't think there is a good health care plan, dental plan. I don't think they exist.
No.
But I saw this plan and I thought this looks great on paper. I wonder how it would actually turn out when you submit a claim to this insurance carrier. But I'm seeing advertisements for dental plans in the $5,000 to $10,000 annual max range on the dental side.
That is wonderful.
Yeah.
That would be so wonderful if they can, at least change with evolution in our time in regards to what we pay, for our cost of living. So that would be wonderful.
Yeah, I think there's definitely an evolution. And then in the state of Washington, a few of my dentist colleagues up there met with a large carrier, and there is some concern among dental insurance carriers that medical is going to start to allow more coverage for the basics of dentistry, like pro fees and fillings, and it's going to completely wipe out the need for dental insurance to even exist.
Wow.
And they are concerned about that. But my thought and feeling is just based upon how insurance works, both dental and medical, is that the larger cases, more and more of them, larger dental cases, will be pushed to medical. And they have been over the last 15
Sure.
to 20 years. But dental insurance will still cover the bread and butter, the basics of crown and bridge and hygiene.
Sure.
But not every patient needs just crown and bridge and just regular hygiene. A lot of our patients need a lot more work. They need sleep apnea devices. They need surgery. They need all kinds of stuff.
Exactly. Absolutely.
And who knows if that's just a trend or if humans have been experiencing these oral issues for thousands of years or not. But it seems to me that the trend in dentistry is leaning more towards the necessity of learning how to bill medical. So you mentioned sleep apnea. Is there, with your experience, the average general dentistry practice, their concern is they get a letter from the insurance carrier saying you're not an oral surgeon, so your taxonomy doesn't fit the criteria for medical billing. Are those some of the things that you have to overcome initially with an insurance carrier when you're starting to get involved with medical billing?
Absolutely. And what's so difficult these days, Ben, so look, I want to make a couple points. One, I want to go back to what you were talking about in regards to the need for medical billing in a dental practice. I really think that, from my experience, being where I am with Arrowhead Dental Lab and working, very closely with Dr. Dick Barnes and what he's taught over the last 40 years, I really think it boils down to the office being comprehensive and looking outside the scope of just teeth, looking at the function of the bite and how the teeth come together and where the jaw sits. And of course, like you just mentioned, sleep apnea is a huge topic and something I've really had a lot of passion and attention on over the last 15 years. And, when it comes to sleep, patients, they need help maintaining and keeping their airway open. So the second point I was going to make is, absolutely, when you start looking at medical billing in a dental practice, there's going to be a lot of little nuances or little hurdles that you need to overcome when you're just getting started. And you're absolutely right. You need to be an oral surgeon and you have to have the right taxonomy and the MPIs and tax IDs and all of these different codes to make sure that you're recognized by them. That is a step that you need to do. And bottom line, when it comes to anything being approved through Medicare, let's say, Medicare's, for 65 and older, there are government insurance, they're the strictest of all strict. And they wrote a policy in January of 2011 that stated that dentists are, the only licensed DDS or DMD to become a durable medical equipment supplier for oral appliances. And the reason this is a big deal is because Medicare said, hey, these oral appliances work. Not only that, we're going to offer a licensed dentist and only a licensed dentist benefit towards doing this type of therapy. So once Medicare sets that, rule or, even their allowable amount, their fee schedule, all private insurance companies now have something to look towards. And my point is that in January of 2011, they wrote this, which was 7 years ago. But the private insurance companies, they're still catching up, if you will. And we're kind of in the pioneering state of all of this. And the reason I bring up Medicare is in order for a dentist to apply as a durable medical equipment supplier, the only option that they have as a dentist on their application is oral surgeon. Mm-hmm. And so when you call Medicare and you walk them through, okay, well, listen, we've got a lot of GP dentists. They want to become durable medical equipment suppliers. They're not technically oral surgeons, but, they are licensed DDS and DMDs per your policy. So Medicare says, well, hey, that's the only option to be a dentist, so go ahead and select it. Gotcha. So as a dentist, you now are saying you're an oral physician is what Medicare feels that you are. And a lot of the private insurance companies, like a lot of the Blues, Blue Cross Blue Shield, they'll follow Medicare to a T. So they'll say, oh, Medicare says you have to be an oral surgeon because it's the only option on the application box. And so we therefore say that you have to be an oral surgeon. So as we see this evolve a little bit more, and as we see Medicare adapt their rules and almost, not necessarily change them, but adapt them to a dental license, we're going to hopefully see a lot of these private insurance companies start changing some of their rules and regulations. But bottom line, you got to get credentialed. That's number one. So recognizing your tax ID and your MPIs and all of that with the insurance company, not necessarily getting in network, but getting credentialed, letting them know who you are, and being able to bill electronically. Those are going to be your first steps.
That's awesome. So basically being recognized by the insurance carrier as a provider that's qualified to do these services.
Correct.
Yeah, that's pretty interesting. So you mentioned something key here, get credentialed with the insurance carrier. So I often get asked this question, what's the difference between credentialing and contracting?
Correct.
And I guess the basic answer is getting credentialed is being recognized by the insurance carrier, having a file with them so that they know who to pay. And also making sure that your license, you have an active license to practice medicine or dentistry. And then contracting is separate. That is the process of becoming an in-network provider and going through all the additional hoops to be vetted out by the insurance carrier to be listed as a preferred provider.
You're absolutely correct.
So when it comes to medical billing, do you believe it is essential just to get credentialed, or is it helpful to become contracted as an in-network provider as well? What are your thoughts there?
That's a great question, Ben. And if you were to look at all of the dentists in the country, I would say about 20,000 of those dentists are making oral appliances for patients that snore or have sleep apnea. But out of those 20,000, I would say there's probably a much smaller percentage of those that actually look to see if the patients had a sleep test, see if they have a diagnosis of obstructive sleep apnea, and then take it a step further to actually bill the medical insurance to receive a benefit for the patient. And then out of the percentage of those that are billing Medicare to do that, there's going to be an even smaller percentage of those guys that become in-network. And so it's just like it is on the dental side. You've got to weigh all your pros and cons. You've got to look at their fee schedule because every insurance is going to have a different fee schedule for what they allow towards the benefit of an oral appliance. And so, any dentist that's looking to get in network or become a participating provider or negotiate a fee schedule, you really want to, make sure that you are in agreement with that fee schedule. For example, Medicare, again, they kind of set the standards, and they do have an allowable benefit in all 4 jurisdictions of their durable medical equipment department. And those ranges are going to be anywhere from $800 up to $1,900. And so it just depends on where you fall on the map of those jurisdictions to decide what Medicare's allowable benefit is. But on their website, on Medicare's website, fee schedule website, for the code E0486, which is the oral device, the durable medical equipment, it says the allowable benefit is 0. So that's hard, because then when you deal with a lot of these blues, Blue Cross Blue Shield, they'll say, we're going to give you 300% of what Medicare's allowable benefit is. So for the provider, for the dentist, that means it's a $300 benefit. And that just doesn't cut it, because most times your lab bill to have the oral device fabricated with a dental lab is going to be more than 300. So, it's not advantageous for a dentist to become in network if you're looking at a fee schedule like that.
Right.
So just like anything, just like when dentists are signing up with PPOs, you've got to look at all of the things involved and understand if they already have a dentist in network for this procedure, they may have already set that fee schedule for you. So coming in as a second provider, you may have no negotiating power, so it's something that you've got to look at everything. And, I truly believe on the dental side, if you have a good service, charge for that service, have a fair fee, and make your patient responsible. However, let's do everything we can to help our patients maximize and get benefit back. So that's kind of my 2 cents.
No, absolutely. You mentioned a couple of things here, one of which is Medicare. So many doctors, many dentists look at Medicare and they don't want to touch Medicare simply because it's, all the regulations. I get calls and emails earlier this year saying Medicare is asking us to do this 2-hour training online and for compliance and this and that. I don't even see any Medicare patients. So people are scared of it. So when it comes to sleep apnea, is it a requirement for you to get involved with Medicare?
Nope, not at all. So bottom line, I agree. If you're going to bill Medicare or get involved with it, you've got to get fully educated on the whole ins and outs, because now we're talking about dealing with the government. And unfortunately, they have rules and regulations. They have a very, very specific way of how they want you to do everything. And they don't call you out on it. They don't, just all of a sudden say, hey, did you do what I asked you to do? They only do that in the event of an audit. So it can be tricky, because a lot of times dentists can get information that, I don't have to do this or that. I don't do this. I don't follow that rule all the time and I still get paid. But in reality, if they were to get audited, they wouldn't need to pay that back, and exactly all of that. So it gets to be a little bit tricky. But here's the real, this is basically how I feel. Medicare is very black and white with their policy when it comes to obstructive sleep apnea and oral devices. They're very, very clear as to what they want the dentist to do and not do. Once you understand that, once your team is trained on that and you have, systems in place to make sure that you match that, I think it's pretty darn easy. And in fact, Medicare plays very quickly, like within 2 weeks. And I feel it's actually fair, the fee that they pay. And typically patients that have Medicare have a secondary insurance or a supplemental insurance, which Medicare automatically bills. So if you set yourself up right as a dentist, if you're set up with Medicare correctly, it can actually be very, very beneficial for you, because your patient would pay everything up front, and then your patient can get reimbursed by Medicare and the secondary insurance. And sometimes it's all the way up to your asked fee. So the patient may get reimbursed 100%. So Medicare actually really works well. It's just a matter of understanding it. So just quickly, I could break it down for you. Yep. Bottom line, Medicare Plan B is what most dentists think of when they think of Medicare, and that's office procedures. So that's seeing patients for an exam, for an x-ray, for an extraction. And I would say the majority of dentists I know have opted out of Medicare Plan B. They don't want to bill any of those procedures to Medicare Plan B. Right. And I think that's actually a good move, because there are not a ton of procedures that qualify for medical necessity through Medicare Plan B. And if they do, the amount that they reimburse may be very low. So unless you're seeing a ton of Medicare patients and you have a lot of procedures that can be billed medically, it may not be worth it to become a Medicare Plan B provider. But the good news is that oral appliances for obstructive sleep apnea are considered durable medical equipment. So they are under a completely different department of Medicare. They're under Medicare DME. Now, Medicare DME does fall under Medicare Plan B, but they are separate. So most of my friend dentists have opted out of Medicare Plan B, which is office procedures, but they have enrolled or signed up to become a durable medical equipment supplier.
Ah.
And when they do that, Medicare wants you to have the same status with Medicare Plan B as you do your DME. So most dentists go into Medicare DME as non-participating, since they're non-participating on the Plan B side, or they've opted out on the Plan B side. So that's good news, because when you go in as non-participating Medicare DME supplier, which, by the way, there is an application, they do a site visit, they come to you and make sure that you're real, and you do have to pay to apply for this. But once you become a DME supplier, you now, as a non-participating DME supplier, have the option on a case-by-case basis whether or not you want to accept Medicare's assignment. So what that means is, if patient A walks in the door and you say, oh, we've got oral appliances and you qualify and everything looks good, our fee for our oral appliance therapy is $2,800, your patient can get a benefit back from Medicare directly. And so your patient can get anywhere from $800 to $1,800 back from Medicare. And if they have a secondary supplemental insurance, Medicare will bill them automatically. So your patient can get a second check all the way up to their full fee. So that, in essence, to me, is the best way to do it. And obviously, you do have the choice. So if patient B walks in the door and you say, our fees are $2,800 for oral appliance therapy, and patient B says, oh my gosh, I have no money. What are you talking about? Medicare pays for everything. You could, out of the kindness of your heart, go ahead and accept assignment, which means that Medicare will pay the provider directly. Right. And it just depends on what jurisdiction you're in to receive that allowable benefit. But it's kind of like you have the best of both worlds if you go that route.
That's pretty awesome. I wonder, do you offer classes on this type of stuff? Because it seems like to me, I mean, you're so well versed.
I do, Ben. So I'm on faculty with the Pankey Institute. I teach at their dental sleep medicine course. I'm faculty with the SPEAR education group. So at all of their dental sleep medicine courses, of course, I'm on faculty with Arrowhead Dental Lab. And we teach a dental sleep medicine course twice a year that I explain that through. Also on faculty for AGD and ADA. So I hold courses with all of those aspects. And right now, there is an online course through the ADA that walks you through medical billing for oral appliances that I put up. So, you're more than welcome to go to the ADA's website. It's ADACElive.com, I believe. So there's a course going on right there. But yeah, there's tons of stuff that we can get everybody educated on, because it does get tricky. And like you mentioned earlier, Medicare directly, they have courses that will walk you through, exactly what I'm talking about, whether you opt out of Medicare Plan B or want to become a DME supplier. They take you through their online courses as well. So there's definitely some resources out there.
That's pretty amazing. And I guess one of the questions that I know our listeners are thinking is, so if I'm going to get into medical billing, especially for sleep apnea, is it necessary for me to deal with Medicare? Am I going to run into that? And if so, sounds like it's a good idea to learn it. But is it something that most doctors run into that do sleep devices?
I would say in my last, 15 years of just fully focusing on sleep, absolutely. Okay. And the reason is because as we get older, our airways get more collapsible. And as, you start to work with physicians, a lot of dentists, they want to get a lot of referrals from physicians in the area. Most of the time when you reach out to physicians, they're going to say, can you bill Medicare? Do you take Medicare patients? And it's mainly because the large percentage of patients they see with obstructive sleep apnea are, 65 or older. So in my experience, I would say yes. Do what you can to help those patients that are of Medicare age or have Medicare insurance. And again, I guess it just depends on if you're a dentist that maybe isn't wanting to get heavily involved in dental sleep medicine, but just treat the patients that you have in your practice and you don't have a high percentage of 65 or older patients, then I might say, hey, I wouldn't worry about Medicare right now. But if you're looking to really make a name for yourself in sleep or starting to help a lot of patients in your community, more likely Medicare is going to pop up. And from what I've experienced, in my opinion, I would say about 50% of insurance companies out there have adopted Medicare's policy. So it's like, hey, if I'm going to have to go through it with a private insurance, I might as well go through it fully on with Medicare and help all those patients that, are 65 and older.
Absolutely. Well, that makes perfect sense. So I guess the message is that you can never escape Medicare, especially if you're going to deal in this area of dental sleep medicine. It's worthwhile to look into it. Now, you mentioned a couple of interesting things. 20,000 dentists do some type of dental sleep medicine, and then even a lot less than that actually bill insurance. So would you consider the sleep medicine side of dentistry an opportunity?
1,000%. If you just look at the statistics of people that have undiagnosed obstructive sleep apnea, about 85% of people that have it are completely undiagnosed and have no clue. So you've got to look at that being in your general dental practice. Your everyday general dental practice has on average about 27% of those patients having obstructive sleep apnea. And then again, 85% of them have no idea that they have it. Personally, I think that number's a lot higher. Mm-hmm. And especially if you are a dental practice that is wanting to get involved with just, the whole airway movement. Obviously our conversation today has been about obstructive sleep apnea, which is because it's medically necessary to be treated. And there's policies that allow benefit towards it. But what about all those millions and millions of people that don't quite have apnea, but suffer from something called upper airway resistance syndrome, or UARS. It's basically a fancy word for snoring. It means that there's an obstruction in your airway that's waking you up out of your sleep cycle or, disrupting your sleep cycle. And so it may not be doing damage like apnea where you stop breathing for a certain amount of time, but it's still stopping your sleep cycles, which is still not healthy for you. And so there's practices everywhere that are starting to get involved in how can we help those people, even though there's not going to be benefit coming back from their medical insurance. And so it's going to be fascinating as we see dentistry start to take a look at airway and how airway plays a role in our teeth and our occlusion, in our sleeping and breathing. So I think that we're going to start to see that become more and more apparent.
That's awesome. My observation of doctors that do sleep apnea, and it's hard to find those that do it. Like I don't see any advertisements in my community, and there's a ton of retirement communities nearby. And then, Utah's not necessarily, a state that suffers with large number of obese patients that would typically fall in that risk category for sleep apnea. But wherever I go in the country, I just don't see it heavily advertised out there. But for those that do sleep apnea that I know of, they're so busy. They just seem to be booked. Some way, somehow, patients find them. And it's an opportunity. I think it's one of the more younger opportunities in dentistry in terms of clinical services that still trying to find its way in the dental practice or more dental practices out there. So
exactly. And once you get bitten with that sleep bug, once you figure out the connection of how a dental office can really play a huge role in airway, I mean, the sky is the limit. And, a lot of my clients, a lot of my friends that, lecture and present all across the country, I mean, they're exclusive, all on dental sleep medicine now. So yeah, the opportunity is huge. And the big thing that we're working on with the ADA is bringing awareness to pediatric airway. So we're so excited to have our our very first meeting at the ADA headquarters at the end of August. And we're bringing in some huge researchers with pediatric airway to discuss this and hopefully, create a movement to make this a whole, side profession for dentists to start looking at how airway is a big thing, in the dental practice and not just with adults, but how we can step in and possibly intervene to have a more positive, airway growth experience, if you will.
I really like that because you're seeing more and more services exit the dental practice. For instance, the Sonicare, where in the past, the only place I knew where to buy one was at the dental practice. Now you can buy it on Amazon. Or ortho. I mean, you see these ortho appliances being sold and advertised on ESPN, and orthodontists are getting really ticked off, thinking that the public is just trying to bypass the professionals that'll keep you safe.
Exactly.
And now you see teeth whitening. A football player came out with an advertisement with at-home teeth whitening kits that basically says you don't need to go to a dentist to get this; just buy it here. I like that there's initiatives on creating more added value opportunities for doctors in dentistry to engage with the patients to get them healthier. So I love what you're doing. And last thing I'll say is that I'm Samoan. So Samoans on average, 90+% have sleep apnea throughout their lifetime. And it's in a large part towards a lack of dieting and exercise. Well, we diet, we live in the islands, and so we really diet. We eat everything that we see. And so naturally what occurs is Samoan people are heavy snorers. In fact, I was on the Hawaiian Air flight from Honolulu to American Samoa last month. And last minute flight, so we were kind of forced to purchase the business class tickets where the seats lie flat. Great for a 5-hour flight, but not so great when it's a red eye and you're jam packed with a bunch of other Samoans, and it was a snoring competition the whole way there.
And then, you needed earplugs on that flight.
They did. They didn't work though. So in front of me was a guy, and he was struggling to breathe. I thought he was gonna die on the flight because he was really struggling to breathe, and he was sitting straight up. It's like, and it's becoming a problem, not in not only in third world countries, but here in the United States as well, where sleep and sleep related deaths are on the rise. It seems like. So I like.
It's sad because it's preventable.
Yeah.
We can give all of those people in first class an oral appliance, or my favorite product, nose cones, which will keep their airway open, and then we won't hear them breathe, and they'll be totally fine.
We'll partner with Hawaiian Airlines to advertise sleep devices on the flights for them.
I like it. Let's do it. Yes.
Yeah. Well, Glennine, you're so knowledgeable in this area, in this space, and there's so many questions I'd love to ask, but I know your time is valuable. So if listeners want to learn more, of course, if they want to learn from you directly or attend one of the meetings, and I should have done a better job laying out your credentials like you just did a couple of minutes ago with the Pankey Institute and all these well-known organizations that you lecture for. Is there a way for people to find out when you're lecturing and or if they can learn from you directly or through a webinar, through Arrowhead or any other organizations?
Absolutely. So you can go to my website, which is DSM, which stands for Dental Sleep Medicine. So dsmbootcamp.com. And on that website, there is a tab for courses. And I usually list out all the courses that I'll be attending or be speaking at. And you'll see all the courses that we have going on through Arrowhead, all the courses that I'm involved with Pankey and Spear and ADA and AGD. And I try to keep that up, keep that on all year long and update it as courses come about. So yeah, you can find me there. But if you just simply call Arrowhead or email Arrowhead, they'll be more than happy to set something up. If it's a private training we need to do, or hey, even if you've got an office where it's like, hey, there's 5 of us that we want to get you in, we can do that too. That we've done that before. So there's a lot we can do. And I do have I'm super excited for collaborating with a couple of other amazing medical billing minds coming up here in the future. So I've got a couple of meetings that we've got scheduled in August to discuss a couple things, but hopefully we're going to have just some more resources available for dentists that want to learn more in regards to medical billing and what they can do. Because, like you said, there's a lot of products, a lot of education out there, but sometimes it's just good to kind of get a view of the whole picture and then look at what your options are for software or for medical billing services or whatever the case may be.
Yeah, I like that. I think most are thinking, can I get a starter kit somewhere?
Exactly. Let me know what's going on.
Yeah.
And so we do all of that through Arrowhead. So like I said, don't hesitate to reach out. My email is gvarga@arrowheaddental.com. So you can reach me either on my website or through the email, whatever works best.
Awesome. And we'll post all of those in the show notes, so that for those of you that are driving or doing something else, you can simply click on those resources in the show notes. Glennine, thank you so much for being on the podcast today. I think this is I learned a few things, very enlightening and educational. Would love to listen to you lecture for a couple of hours on these things, because I think this is definitely an area that we get a lot of questions on, and this is not, of course, our area of expertise. So thank you for sharing your knowledge, and most of all, thank you for spending time with us on the program today.
No worries. Thank you for everything. And again, just let me know what you need. You know where to find me. I'm more than happy to help anybody through any of this.
Awesome. Folks, again, this is Glennine Varga. Thank you so much.
Okay. Have a great day.